Welcome to the Caladrius Health channel. This is the first article in our series exploring India's Ayushman Bharat digital mission and the foundational infrastructure reshaping how health data moves across the country. Today, we're going to cover the real-world problem of clinical data fragmentation, why it exists at such a massive scale, how ABDM differs from NHCX gateways, the core architecture, our current adoption progress, and finally, the strategic imperatives for health IT leaders. Section 1. The real-world problem. Let's look at what clinical fragmentation actually looks like on the ground. Picture this. A patient gets a CT scan at a private hospital in Chennai. A few months later, she relocates to Pune and goes to a new hospital for follow-up care. The structural challenge here is that the radiologist in Pune doesn't have any access to her earlier imaging or baseline diagnosis. Those clinical records simply don't transfer over. So what happens? A duplicate scan is ordered. This perfectly illustrates our current operational reality. Without shared clinical infrastructure, records just don't follow the patient, resulting in a complete loss of clinical continuity. Section 2. Why fragmentation exists. You see, this fragmentation isn't a failure of individual providers. It's a structural challenge stemming from India's highly distributed healthcare landscape. The system is built across thousands of independent silos. Just looking at the public side, there are over 1.69 lakh subcenters and more than 31,000 primary health centers. Then you have a massive private sector handling about 80% of outpatient visits, ranging from large corporate chains to small solo clinics. Add in a highly fragmented diagnostic lab ecosystem, and it makes sense why clinical notes, lab results, and discharge summaries usually remain isolated, exactly where they were created. You might think electronic health records would naturally solve this, but India faces a significant EHR adoption gap. While countries like the US moved from around 9% to 96% EHR adoption through specific policy incentives, fully paperless EHR implementation in India is still quite low. Most sophisticated deployments are heavily concentrated in large corporate hospital chains. For the vast majority of patient interactions, traditional paper records still dominate. And the crucial point here is that achieving true clinical interoperability takes a lot more than just buying software. Facilities need to generate structured digital records using specific coding and transport standards. In India, this is defined by the FHIR, pronounced FIRE, implementation guide for ABDM, specifically version 6.5.0. It mandates standards like ICD-10, SNOMED-CT, and LOINC, and requires HL7 FHR R4 transport standards. Outside of the large chains, the specific digital capability is pretty limited right now. Section 3. Distinguishing ABDM from NHCX. This brings us to a really important architectural distinction. Since you're likely familiar with our NHCX content, you know NHCX addresses the standardization of cashless claims exchange. It handles the billing and insurance routing. ABDM, on the other hand, solves an entirely different infrastructure problem: clinical data interoperability. They are two distinct gateways serving entirely distinct operational goals. Section 4. ABDM's core architecture. Let's break down the core digital architecture of ABDM, designed specifically to bridge this clinical gap. The first building block is ABHA. This is a 14-digit unique health identifier. Think of it as the patient's anchor identity across the entire ecosystem. It's essentially the single patient-controlled account that lets clinical records from multiple independent providers be linked together securely. Next, we have the verified directories, the Health Facility Registry, or HFR, and the Health Professional Registry, the HPR. Basically, you can't reliably route national health information between providers unless you have a verified infrastructure identifying exactly who is sending and receiving it. These registries act as that verified directory for both facilities and individual practitioners. The fourth component is the HIE-CM, the Health Information Exchange and Consent Manager. This is the gateway where the data actually moves. But importantly, ABDM operates on a federated architecture. Data isn't stored in some massive central database. It stays right at the originating facility and is only shared through the HIE-CM gateway when there's explicit, time-bound, and revocable consent directly from the patient. Section 5. Adoption progress and realities. Looking at the adoption metrics, there's clear, measurable momentum. As of March 2026, we're seeing 866 million ABHA accounts. That's 86.64 crore registrations. The number of linked health records has hit 90.70 crore. Alongside this, over 2.5 lakh, or 256,542 to be exact, facilities are now actively using ABDM-enabled software. We're already seeing the practical impact of this on the ground. A great example is the scan and share feature. Across over 17,000 integrated facilities, outpatient departments can digitally retrieve patient details instantly via ABHA. This operational shift has successfully reduced OPD wait times from 30 to 40 minutes down to just 5 to 10 minutes. Still, scaling account creation isn't exactly the same as achieving full functional interoperability. As expected with any national-scale digital rollout, there are implementation realities where work continues. For instance, there's an uneven software integration gap. About 4.17 lakh facilities are registered, but only 2.56 lakh are active. We're also navigating state-level adoption variations, gaps in EHR readiness at smaller facilities, and very real internet connectivity limitations in rural areas that affect these digital exchanges. Section 6. Why this matters for health IT leaders. So, why does all this matter for hospital CIOs and tech teams? Well, first, just look at the market trajectory. India's digital health market was valued at roughly $8.8 billion in 2024, and it's projected to reach nearly $47.8 billion by 2033. ABDM is the foundational layer enabling this massive market expansion, providing a very clear incentive for hospital leaders to adapt their systems today. Operationally, this integration means more than just a quick software update. IT teams need to map their current hospital information systems, lab information systems, and PACS infrastructure against the ABDM building blocks. You'll need to prioritize modules that are FHIR-ready, FHIR-ready to handle structured formats, and crucially, you should be planning your ABDM and NHCX integrations as parallel but entirely distinct work streams. In the next article in this series, we'll examine how consent-based clinical record exchange works in practice inside the ABDM architecture and what it means for providers preparing for deeper interoperability. This is CaladriusHealth.AI, tracking the infrastructure shaping the future of healthcare operations in India.